All right, good morning again. Next lecture, which is the first of a series. So the next three lectures really are like one big um, 3 hour lecture, which I will divide up for you, um, which follows logically after the cardiac cycle lecture that we spoke of. We're going to start first by a few distinctions between the right ventricle and the left ventricle. Remember when we studied the cardiac cycle, I was telling you that we're going to use the LV as an example, but then that everything I say about the left ventricle applies to the right ventricle, except that things happen at a lower pressure. Um, However, there are a couple of differences you need to be aware of between the right and left ventricle. So the right and left ventricle are not mirror images, and the fact that the RV works at a lower pressure is not the only difference. There's a few differences between what happens in the RV and LV. First, anatomically, the idea that the heart has a right ventricle, left ventricle divided by a wall called the septum is not entirely true. If you look at this diagram, left side or right side, you will see that this is actually how the heart is. So, really, what the heart consists of is a left ventricle, a thick, conical structure, which is the left ventricle. The septum, as you can see, is part of the left ventricle. So, you have a thick, muscled, cone-shaped structure, which is the LV. And against the LV is the thin-walled structure, which is the right ventricle. The way the right ventricle and the left ventricle eject blood, therefore, is slightly different. If you look at the right side, you have a long axis and short axis of the left ventricle. The left ventricle ejects blood simply by obviously contracting and therefore shortening along its short axis, as you see in number one, and its long axis. So it's as if you're squeezing a towel. The short axis shortens and then the long axis shortens and therefore propels a certain stroke volume of blood outwards. On the left side, if you look at how the right ventricle propels blood, the right ventricle free wall, which is very thin, starts to shorten and then it contracts against the septum. So the septum thickens both ways. So when the septum contracts and thickens, the septum is a muscle, it's not just a wall. It helps propel blood, so it thickens also towards the RV, and the free wall of the ventricle contracts against it, just like it pushes itself against it, therefore propelling blood. This is as far as anatomical differences. Second, are some physiologic differences. So, the cardiac cycle now you're aware of, and we're summarizing it here in the middle figure. Remember, phase one, same colors, which was kind of light purple, um, and then the isovolumic contraction, ejection phase, isovolumic relaxation. So if you want to summarize the cardiac cycle, if you look in the middle part of the figure, you will see where the mitral valve closes, aortic valve opens, and so on and so forth. So in red is the isovolumic contraction, in green the isovolumic relaxation. In the right ventricle, you have the exact same thing happening, except that the isovolumic phases are briefer, are shorter in time. The reason that is because the right ventricle and the pulmonary circulation are much lower pressure circulation. Therefore, if you think of the isovolumic contraction, what is the isovolumic contraction? Is the time it takes for the ventricle to generate enough pressure after closure of the mitral or tricuspid until pressure reaches the pressure in the whatever artery the ventricle supplies. So on the left side, the reason it takes time is because it takes longer for the LV pressure to rise from a very low pressure, which closes the mitral valve, all the way up to whatever 80, 90 millimeters of mercury, which is the aortic diastolic pressure, at which point it reaches it and kicks the aortic valve open. On the right side, the right ventricle contracts, tricuspid valve closes. Again, we're looking at the middle portion of this graph. But then the RV doesn't have to generate much pressure until it reaches the pulmonary artery pressure, because pulmonary artery pressure is If the aortic pressure is 120 over 80, pulmonary pressure is something like 30 over 15. It's nothing. So it takes a very brief time for the RV pressure to reach that and then open the pulmonic valve. Therefore, isovolumic contraction is briefer, and same thing along the same logic, isovolumic relaxation in green is briefer. So the time between closure in diastole, closure of the pulmonary valve, and opening of the tricuspid is also briefer. The implication of that is that the ejection time, shown here in like this light beige color, the ejection time is longer. So the RV therefore ejects the same volume of blood, of course, as the left ventricle at a lower pressure, but the systole, the systolic portion of the RV when the pulmonic valve is open is longer. So it takes a bit of a longer time until the pulmonary valve closes. This is number one. Second implication is that we spoke of the heart sounds and we said, what is the second heart sound? It's the closure of the aortic on the left or pulmonic on the right side. The implication of the fact that ejection time of the right ventricle is longer, the right ventricle is ejecting blood into such a low resistance circulation, the pulmonary circulation, low pressure, low resistance, that the RV can keep ejecting longer than the left ventricle until the pulmonic valve closes, which means that the pulmonic valve, once the heart goes into early diastole, the RV is still lagging behind a bit because it's pushing blood, it's very relaxed, it's pushing blood into a low pressure circulation, and therefore the pulmonary valve, as you see here in the figure, will close with a bit of a delay, a bit of a lag as compared to the aortic valve. So therefore the second heart sound, S2, which is supposed to be A2 plus P2, effectively is A2 then P2. There's a tiny bit of a lag between closure of the aortic and closure of the pulmonic. And here, I've drawn them for you. First, I put the arrow over the ejection time. Clearly, the RV takes a bit longer to eject. But then A2 is the aortic component of the second heart sound. So when we say A2, it's aortic valve closure. And P2, which is pulmonic valve closure, have a bit of a lag. And therefore, really, effectively, S2 is not one heart sound, it's two very close heart sounds to each other. Aortic closure, pulmonic closure. And this is what forms the basis of what we call the physiologic splitting of S2. What is the physiologic splitting? Physiologic splitting means that S2 at times is split enough that you can hear it with your stethoscope. Instead of being one sound, it is two sounds. And what is physiologic splitting is the variation of the sound with respiration. So I'm going to explain this. If you take a deep breath, in inspiration, how much blood returns to the right ventricle? Does inspiration increase venous return or decrease it? It increases it, because in inspiration, you create a negative intrathoracic pressure, therefore sucking more venous blood from the vena cava to the right atrium and the right ventricle. Therefore, in inspiration, the right ventricle fills with more blood. Therefore, in inspiration, the right ventricle will have a slightly higher volume than in expiration to deal with, to eject. And therefore, it will take it even a bit longer. Therefore, in inspiration, pulmonary valve closure is delayed even a little more than in expiration. And this is what the physiologic splitting of the second heart sound is. Physiologic splitting simply means this is normal. This is not pathologic, it's physiologic. That when you listen to a patient, at times, you will notice that as he's breathing, with inspiration, the second heart sound splits, as opposed to being a single sound, like this. And that splitting is normal in inspiration. You will be asked about these things in step 1 and step 2. And I'm going to give you a second example of a pathologic splitting of S2 this time. Is that babies born with a hole between their atria. The atrial septum has a hole in it called ASD, atrial septal defect. In these babies, there is always a a shunting of more volume of blood from the left atrium to the right atrium, and therefore to the right ventricle, meaning at all times, whether you're in inspiration or expiration, the right ventricle is getting more blood than normal babies, and therefore has to deal with more blood. And therefore, in these patients, in these babies born with this atrial septal defect, there's always a lag, and S2 is always split. And therefore, this is called fixed splitting of S2, and it's not physiologic anymore. So babies born with an atrial septal defect have always, throughout their respiratory cycle, always a splitting of S2. S2 is always split, and this is what gives you a hint that they have this defect. I can guarantee you, I can promise you that on step 1 of your boards next year, you're getting this question. So just remember that a fixed splitting of the second heart sound is an atrial septal defect. And therefore, this is it. You're familiar with this slide. Just remember that S2, which is closure of the aortic pulmonic, effectively is two heart sounds which at times move slightly away from each other and can be split. Therefore, if we put the right ventricle and left ventricle pressures, like we studied in the previous lecture, on the left you have the right ventricle, clearly way lower pressure than the left ventricle on the right. As you see, the left ventricle generates up to 120 millimeters of mercury. The RV generates 25, 30 millimeters of mercury. The outflow velocity, linear velocity, in the left ventricle is faster because the LV is thicker, generates more energy and more kinetic energy too. The RV blood flowing in linear velocity through the pulmonic valve is slower, but takes longer. So slower in meters per second, but the RV has longer time to eject. The final result is both will eject the same cardiac output. The cardiac output of the right ventricle per minute is exactly that of the left ventricle per minute. But because of lower pressure, because of lower velocity, less energy, and therefore less energy consumed. The RV does it by consuming way less oxygen and way less energy. All right, so next and over the next few slides, we're going to move on and look at how cardiac pressures and volume interact with each other. And I'm going to explain this to you in a bit and the important implications of that. First, brief review. Now you're familiar with this, so you know what the cardiac output is now, and that's stroke volume times heart rate. So the cardiac output per minute is stroke volume per heartbeat times how many beats you have per minute. And there you will have the volume of blood ejected per minute. And stroke volume is the difference between end diastolic volume and end systolic volume. So if we're talking left side, it will be LV end diastolic volume, etc. Right side, it will be RV. And the ejection fraction is the ratio of the stroke volume over the end diastolic volume, meaning what percent of the end diastolic volume, what percent of the total volume, maximal volume that the ventricle accommodates is ejected. Normally, this is, get very familiar with this concept, EF, ejection fraction, because you're going to use it for the rest of your lives. Ejection fraction is clinically the variable or the number we look at the most when we talk about patients undergoing echocardiograms or cardiac cath or having any pathology in their heart is always the ejection fraction. In normal ejection fraction, you and I have an ejection fraction above 50%, 55, 60, etc. So anybody whose ejection fraction is above 50, even 50, we would call it fair, but 55% and above is considered normal. If you have an ejection fraction of less than 50%, your left ventricle has a problem. Your left ventricle has a problem. And of course, there are degrees of abnormalities in that sense. Now, I put the slide for you and summarized these pressures for you for a reason that A lot of times I show you a formula and tell you there are things you don't have to memorize. Uh, these numbers, however, you have to be familiar with. Remember, they're not carved in stone, meaning no one's going to ask you, for example, if you start with the right atrial mean pressure of 2 millimeters of mercury, if a normal pressure is 2 or 3 or 4. These are all normal. But these are approximate numbers. And all of these are in millimeters of mercury. So if you start, I'm not going to read the slide for you, but if you start on the right side, as we said, the right heart works at much lower pressures. So the right atrial pressure is nearly zero. There is no pressure in the right atrium. 2, 3 millimeters of mercury. Right ventricle, same thing, 25, 30 in systole. The RV end diastolic pressure is 6, etc. PA systolic, PA diastolic, mean PA pressure around 15. Just have an idea. So you should be, I don't want you to memorize them per se as a number, but you need to know that a normal pulmonary artery pressure is roughly 30 over 8, over 10, over 12. But a normal PA pressure cannot be 50 or 60 millimeters of mercury in systole. That's too high. And so on and so forth. Of course, if you look on the right side of the screen, the left-sided pressures you're probably more familiar with. So you know what a normal aortic pressure is in systole and diastole, and therefore the mean, etc. However, two little things I want to illustrate for you is what we call the pulmonary capillary mean pressure and the systemic capillary mean pressure, meaning there's a mean pressure inside the capillaries. And of course, you know that by the time blood reaches the capillaries, it has a much lower pressure than the arteries that supply these capillaries, and now you're familiar with why that is. So as blood goes from large to medium to small arteries, crosses the arterioles, and reaches the capillaries, the pressure has dropped a lot because blood has crossed the arterioles, which are vasoconstricted parts of the vasculature, and are parts of the vasculature which have where blood loses most of the pressure and most of the energy. So how do we measure mean pressure in capillaries? So for example, the mean pulmonary capillary pressure is 10 millimeters of mercury, but they're microscopic. And how can we clinically have an idea what the pressure in these capillaries is? Because remember what I told you, the mean pressure in the pulmonary capillaries, which is a reflection of the LV end diastolic pressure, by the way, and we spoke why that is. This mean pressure is very important because it's felt by the patient. And if the mean capillary pressure in the lungs, pulmonary capillary pressures, rises, you reach a point where the hydrostatic pressure in these capillaries can first impact the oxygen exchange between the alveoli and the pulmonary capillaries. And more importantly, if it rises enough that it exceeds oncotic pressure, you can start leaking fluids from the capillaries into your alveoli, and this is what's called pulmonary edema, which is a life-threatening situation. So I'm going to show you in the next slide, clinically, how is it that we can measure the mean capillary pressure in the lungs. So here's an illustration of how we measure wedge pressure in capillaries. That's why we call it wedge pressure. The mean pressure in capillaries, obviously, you don't have a catheter small enough to put in capillaries. All the pressures I showed you, even in the previous lecture, when I showed you actual examples from our own patients of graphs of aortic or left ventricular pressures, how are these measured? We put catheters through any artery all the way to the aorta or to the left ventricle, and these catheters are fluid-filled with saline, and they detect pressure. And this pressure detection is the catheter is connected to a transducer, which translates these pressures to a graph that you see in front of you. Now, if you introduce a catheter, and always the catheter measures pressure from its very tip. That's what a catheter is, a tube. And it measures pressure from its very tip. But right before the tip is a balloon that we can inflate from a distance with air, just with air. until this catheter reaches one of the pulmonary arteries, for example. So if you look at this figure, it's very easy to introduce a catheter through any of the veins, jugular vein, femoral vein, and slide it all the way to the right atrium. And you can stop there and measure right atrial pressure. Then into the right ventricle and measure RV pressure. Then into the pulmonary artery, where you see it sit in this graph, and measure pulmonary artery pressure. But how is it that with the same catheter we can get an idea about the mean pressure in the capillaries, which are tiny and which are further away from where the catheter is sitting here? If this balloon that you see is inflated, just like you see in this figure, enough that if you keep pushing this catheter, the balloon will wedge itself. This is why it's called wedge pressure. It wedges itself into one of the branches of the pulmonary artery, therefore isolating the tip of the catheter from what's behind it, and therefore also occluding flow. So blood cannot enter this artery anymore. What happens is you don't have anymore a systolic and diastolic pulmonary artery pressure to measure because you have occluded this artery, but you're measuring pressure beyond the occlusion. And therefore now you have a static column of blood. Blood has stopped, it's not moving. And a static column of blood connecting this artery to the arterioles that come after it and to the capillaries that come after it. Now you have one system, one column of fluid, and the pressure in this column of fluid is the same. And what is this pressure? It's the pressure in the capillaries. So by inflating this balloon and wedging this catheter into one of the branches of the pulmonary artery, you will have, or you will measure, what we commonly call clinically wedge pressure, but what is in fact mean capillary pressure. And this is something commonly used, as you see in the figure. It's called a Swan-Ganz catheter just after the two people who invented it. But in fact, it's a pulmonary artery wedge pressure measuring catheter. And this is what allows us to measure the mean capillary pressure.